Boa noite a todos. Declaro aberta a 12ª sessão ordinária relativa ao 193º ano acadêmico. Está em discussão e aprovação a ata do dia 2 de junho de 2022, que os senhores acadêmicos receberam por e-mail. Se alguém tiver alguma retificação ou algum comentário sobre a ata, por favor, se manifeste. Não havendo nenhuma manifestação, a ata está aprovada. Declaro aberta a vaga da cadeira número 11 da secção de Medicina, cujo patrono é Antônio Austregésimo Rodrigues de Lima, e o ocupante anterior foi o querido acadêmico José Rodrigues Cora, falecido em 3 de abril de 2021. Declaro também aberta a vaga da cadeira número 77 da secção de cirurgia, patrono Jesuíno Carlos de Albuquerque, cujo ocupante anterior foi o querido acadêmico Hildoberto Carneiro de Oliveira, falecido em 8 de junho de 2020. O período de inscrições dessas vagas vai de 9 de junho de 2022, dia de hoje, até o dia 6 de setembro de 2022. Passo agora a comunicação dos acadêmicos, se alguém quiser fazer uso da palavra. Na plenária, acadêmico Omar da Rosa Santos pede a palavra. Por favor, microfone.
Para passar às mãos do senhor presidente, um livro da nossa produção recente. Muito obrigado.
Acadêmico Omar da Rosa Santos entrega à Biblioteca da Academia um livro de sua lavra, intitulado Fábulas, Trovas e Fatos. Muito obrigado, querido acadêmico Omar da Rosa Santos. Acadêmico Marcelo André Barcinski quer fazer uso da palavra.
Senhor presidente, caros confrades e confreiras, há alguns anos atrás, o laboratório... Estão me ouvindo?
Sim, estamos ouvindo.
O Laboratório de Políticas Públicas da Universidade Federal do Rio Grande do Sul lançou um livro, um edital de um livro, chamado Literatura e Saúde Pública, e abriu um concurso público de contribuições a esse livro. Eu tive a sorte, a felicidade de ter uma contribuição aceita nesse livro. Na verdade, é um conto, uma fábula, que, por coincidência, tem muito a ver com o que está sendo discutido hoje. É uma fábula sobre suínos modificados geneticamente, humanizados geneticamente, e que passam a se comportar como populações humanas. Eu não quero dar mais spoilers sobre isso, mas eu gostaria de doar. São 2 volumes, doar os 2 volumes à academia, e me permito enviar os 2 volumes também privadamente para o professor Silvano Raia, a quem eu cumprimento pelo simpósio que ele está hoje organizando. Muito obrigado.
Obrigado, acadêmico Barcinski. Mais algum acadêmico quer fazer uso da palavra? Ninguém mais querendo fazer uso da palavra. Nós vamos dar seguimento ao simpósio de Xenotransplante. Vou passar a palavra ao acadêmico Silvano Raia para introduzir nossos convidados estrangeiros. E quero solicitar aos nossos convidados estrangeiros que façam suas palestras pausadamente, porque nós temos tradução simultânea para o português.
Obrigado, presidente.
Em nome da Academia Nacional de Medicina, eu agradeço aos nossos convidados estrangeiros, pessoas na fronteira do conhecimento sobre xenotransplante, brindando nossa instituição com excelentes palestras. Acadêmico Silvano Raia, com a palavra.
Pois não, presidente. A seguir ouviremos o professor Paulo Tan, que nos falará sobre o uso de células suínas para tratamento de diabetes tipo 1 e de plexo coroide para o tratamento da doença de Parkinson. Ele nos falará também sobre suínos isentos de patógenos provenientes de uma ilha ao sul da Nova Zelândia. Professor Tan, a palavra é sua.
Good afternoon. Would you like me to commence now? Yes. Mr. President and Professor Raya and the Academia, thank you for this opportunity to share with you our experience with xenotransplantation in New Zealand. So I'm honored to do this on behalf of my colleagues and co-founders of our company, Dr. Olga Gagravenko and the late Professor Sir Bob Elliott. And I also acknowledge the presence and contribution of learned colleagues who have contributed greatly to knowledge in this field. I will be sharing my screen, which I hope you are able to see.
I haven't seen it yet.
No, share screen.
Oh, not yet, not yet.
No, I can't, yeah?
Yes, you can use your screen.
Yes, I'm trying to, and I'm clicking it and share. Yeah. Yes?
Not yet. Now, yes, yes, wonderful, wonderful.
Right, and I'll commence, right. So thank you very much. From the beginning.
Let's put in presentation mode.
Yes. Mode. There we are. The ongoing work in xenotransplantation in New Zealand is based on our pigs. Our pigs are derived originally from the sub-Antarctic Auckland Islands, where they were isolated for about 200 years and are remarkably free of common pig infectious agents, viruses, parasites, before they were brought to the main islands of New Zealand. The pigs were developed by living cell technologies, Diatrans Otsuka, and more recently, Enzeno Limited. Extensive microbiological screening was carried out to establish the herd. As advised by the US FDA guidelines and the US public health guidelines, the microbiological screening of pig herds had to be done in New Zealand and not just the herd of interest. And this is to identify common or prevalent pig infections in the locality that might be relevant to xenotransplantation. So this column here, other herds in New Zealand, and this is the herd that we want to develop. Because such agents have to be excluded from a designated pathogen-free herd, and that repeated testing is essential to avoid false negatives. And the recent focus on porcine CMV, cytomegalovirus, is unfortunate but important, and certainly included in our screening. The exogenous common infectious agents, because they're common in pigs, are far more likely to affect our xenotransplantation program than porcine endogenous retroviruses. And a lot of attention has been put on endogenous retroviruses, the number of copies of PERV genes, but it's important to realize that many of the PERV sequences in the genome are pseudogenes. And you may say that nature has edited them to be non-functional in many instances. So today we focus on PERV-C negative pigs, and also pigs that do not secrete infectious retroviral particles by co-infectivity testing. It is suffice to say that the suitable pigs are only just a start. And there is a long regulatory process. And just suffice to say that we have been involved with Bioethics Council survey, which concluded that people in New Zealand were in agreement with xenotransplantation, provided it is regulated. We have to meet our regulatory health requirements that pig tissues for transplant are manufactured to good manufacturing standards. Testing has to be done by a laboratory that is certified for clinical diagnostics. Academic laboratories may serve as reference laboratories, but most are not certified clinical service laboratories. And we sought advice from the US FDA and the CDC in Atlanta, Georgia. And these steps had to be taken prior to the approval for the first xenotransplantation held in New Zealand. The founder of Living Cell Technologies, Professor Sir Bob Elliott, was the first in New Zealand to develop alginate encapsulated neonatal porcine islets for transplantation in humans. And the concept was to have capsules about 1 millimeter in diameter that serve to maintain islets that are viable, functional, able to receive nutrients, able to deliver insulin in response to rising blood glucose, and be protected from immune attack. And the emphasis then was to not use immunosuppressive drugs. So LCT published some of its data. There was from a very early study showing that viable capsules could be retrieved from a patient who had received alginate encapsulated porcine islets 9 to 10 years earlier. And these are the capsules at implant, and this is what it looked like at laparoscopy. And there were remnants of porcine islets retrieved by laparoscopy 9 years after transplant, and some porcine insulin detected. And it was this that drove the effort to progress with the manufacture of encapsulated porcine islets. So the whole manufacturing process had to be certified as a product of good manufacturing practice, and of course, the clinical trials under good clinical practice standards. Altogether, about 36 patients have received porcine islet implants. And this particular paper reported the first target. So the first aim is to reduce episodes of unaware hypoglycemia in unstable type 1 diabetes. And this is because it is these episodes that are life-threatening. And the first study in New Zealand involved 14 patients. And in summary, the procedure was safe. There was no transmission of porcine endogenous retroviruses. Importantly, the number of hypoglycemic episodes was reduced from baseline and measured 1 year later, right across. The HbA1c was better controlled, not shown on this slide. There was no consistent reduction in the requirement for insulin. Patients still required their insulin. And this project was subsequently taken over by Otsuka Pharmaceutical Factory in Japan. The New Zealand team also supplied encapsulated pig islets in a study with Professor Adrian Abelovich in Argentina. And in the 8 patients, 4 were given doses of 5,000 and 4 given 10,000 islet equivalents, 2 doses of each. And again, the study had to confirm safety. The control of diabetes was reflected by the HbA1c, which showed improvement, as in the middle column. And this is for a prolonged period. There was also a reduction in episodes of unaware hypoglycemia not shown on this slide. The patients still required insulin. And so with encapsulated porcine islets, there are still issues requiring improvement. And I defer to Professor David Cooper's excellent paper shown below. And in this field, it's recognized that the capsules, the site of the implant, the inflammatory response, and the subsequent fibrosis of implanted capsules in the long term all need to be addressed and improved. And of course, recently, the use of gene-edited pig cells has been discussed. Living Cell Technologies proceeded to develop another product using cells from neonatal choroid plexus tissue. The product NT-cell, alginate encapsulated porcine choroid plexus cells, was shown to secrete a number of brain reparative hormones, brain-derived growth factors, glial-derived factors, and such like. And it has been in these capsules has been implanted in a number of disease models. In models of stroke and Huntington's disease. And the published studies show that the implant of NT-cell reduced cell injury, and also increased cell survival. Here in the middle cerebral artery ligation model of stroke in rats, and in the quinolinic acid-induced lesion in the basal ganglia of monkeys, with significant lesion in A, smaller lesion in treated monkeys, and with preservation of cells that you see in treated monkeys, unlike the control group. The studies in humans followed, and these, the studies were done in monkeys here in the MPTP model, and the implant of NT-cell in monkeys showed improvement in motor functioning and also in a number of neurological functional scores. And again, it shows preserved cells in those that are treated with loss of cells shown in the control group, or those given sham surgery with blank capsules. The study went on to human studies, of which there was a pilot study of 4 patients. Right? And these were patients who have failed medical treatment, and they have qualified for deep brain stimulation. And hence these patients have consented to having bilateral cranial electrical implant as standard medical therapy for Parkinson's disease for patients who have not responded well to medications. And the first study of 4 patients showed that the procedure was safe, and in 3 or 4 patients, there was an improvement in the usual Parkinson's disease scores. In the second study, there were 3 groups of patients, given 3 doses. And the 3 groups of patients were followed up for 2 years. And each group had 4 patients treated and 2 with sham surgery. Again, the entire process was safe, and an optimum dose was identified. The purple line running right across is the placebo group, and the light blue line on top shows the optimum dose having better scores that is routinely used in clinical Parkinson's disease trials. And it is on the basis of these studies that LCT has announced that a 3rd trial will be done in Australia. And for this trial, our company, Xeno Limited, will be supplying the medical grade choroid plexus tissues. And this is possible because these pigs have been maintained by us, firstly in a designated pathogen-free environment, and they have to be null pigs, that is, pigs that do not secrete infectious porcine retroviral particles, or PERC negative pigs. And these pigs in this day and age would also be suitable for an organ transplant program, which we have started. I would just like to finish by pointing out that the adult pigs have a body weight of 80 to 140 kilograms, suitable for organ transplantation without the requirement for gene editing of the porcine growth hormone receptor. And these pigs have a history of safety in human clinical xenotransplantation. Thank you very much.
Paul, muito obrigado pela sua apresentação. E passo agora a palavra ao professor Bruno Richard, pioneiro dos transplantes de coração e pulmão na Alemanha e atual diretor-geral da Cardiac Surgery Clinic da Universidade de Munique, que nos falará sobre xenotransplante cardíaco experimental. Professor Richard, a palavra é sua. Professor Richard, we are not listening. We are not receiving your voice, but we are seeing your slides. Chama a moça que está coordenando. Que está traduzindo? Não, que está coordenando. Vamos. Bruno, can you arrange your microphone because we are not receiving your voice? Still seeing your slides.
Now you can hear me, yeah?
Yes, now, wonderful.
Now you don't see my slides, huh?
Yes, no, we see your slides.
Oh, you see my, but I don't see my slides. Huh?
Now it's everything all right. You can go on.
No, I can't go on because I don't see my slides. Huh? Yeah.
Can't you see your slides?
No, I cannot see my slides. Huh?
Your visualization mode is correct?
Yeah, but I can't see my slides. Huh?
Tiago, você está nos ouvindo?
Melhor o Dr. Bruno sair e retornar.
Professor Silvano, o senhor me chamou?
Sim, você pode fazer alguma coisa? O Dr. Bruno não está conseguindo ver os slides que ele vai projetar. Dr. Bruno, perhaps you can shut down and then put it on again. Now we are seeing your slides again. Tiago, o que pode ser feito?
Can you hear me now as well?
Yes, we are hearing you and seeing your slides.
Okay, that's
Yes,
great.
you
I'm
know.
sorry for the delay.
No, never mind.
Thank you for having me, and I will talk on our preclinical studies. The purpose is to end the worldwide donor organ shortage. Now it doesn't move. I cannot proceed.
It should be your right button at yours.
Yeah, I know how to do it. I did it quite often, but it doesn't work. Yeah.
We can wait. We can wait.
Yeah, I tried again. So no, it doesn't. My slides don't move.
Diz que não está conseguindo. O Griffith está aí já.
Now it works. So worldwide, approximately 4,000 heart transplants are done, and the same magnitude of patient of terminally ill is still waiting. This is my group dealing with heart transplantation, and it's a group of veterinarians, of anesthetists, and of cardiac surgeons. So if you would implant not genetically modified heart into a primate, the heart would be rejected within an hour. This is called hyperacute rejection. So another threat is that thrombotic microangiopathy will take part, which means that all small vessels within the heart are blocked, causing myocardial infarctions. So the reason for that is that the two anticoagulation systems of the two species don't match. So to be successful in cardiac xenotransplantation, you have to fulfill 4 requirements. You need stable genetic modifications in biologically safe donor pigs. So you have to deal with antigens, with protein antigens and preformed antibodies in the recipients, with the activation of the complement system and the incompatibility of the coagulation, anticoagulation systems and unspecific inflammation and so on. So they can be done, and these are the modifications we could provide. But as you can see in the headline, we try to satisfy the needs with as few modifications as necessary. And in our preclinical studies, we use GAL knockouts, then the complement regulator CD46, and most important, human thrombomodeling. For humans, we would need to add 2 more knockouts. In respect to biological safety, we found that the table over here, the graph over here to the left, that when our pigs were CMV positive, then the survival time was significantly shortened if compared or in comparison to animals which were PCMB negative. Since there is no vaccine and no established treatment, donor animals must be porcine CMV free. And we developed a test, and that's a protein of the capsule of the virus, and that blocks with antibodies, and then the test would be positive. In our hands and in our belief, we think above there, this is our farm, and almost all pigs in Germany are PCMB positive, and so to avoid that donor animals get infected, one has to take them away from the mother after drinking the colostrum, and we do that effectively. You can see that that's the milk supplied, and the piglets drink the milk, and the mother is not there. The donor pigs must also be C negative. The second requirement is I think, non-nephrotoxic immunosuppression, and that in that part we follow the lead of Muhammad Mohyeddin, and that he treated his hearts with the immunosuppression I will show you in a moment. And the donor hearts survived up to 3 years, mean approximately 1 year. And so he used CD20, ATG at the beginning, then the anti-CD40 antibody, and maintenance immunosuppression consisted of MMF and anti-CD40 antibody. And the methylprednisolone was tapered down. Unfortunately, he used abdominal heart transplants. The heart, the aorta of the donor pig was attached to the abdominal aorta of the recipient, and the efflux of the venous blood of the heart was via the pulmonary artery was attached to the inferior vena cava. So that resembles a motor car in no gear. The motor is running, but the car is not moving, since the heart is not included in the circulation. It's beating while the coronary arteries, but is not producing a cardiac output. For a preclinical model, the model must be life supportive. It was suggested to have an experiment series of 10 consecutive animals, and 6 of them should survive in good health for at least 3 months. Our model was orthotopic heart transplantation, heart replacement. You cut out the heart of the baboon and replace it with a genetically modified pig heart. Now, if you do that, you run into another problem, that is successful porcine heart preservation. It's a big surprise for us and others. If you apply the techniques you do every day in humans, so static cooling, that does not work. And we introduced, this is static cooling. You see the human heart in the plastic bag, and that was stopped with the solution. And then you put it on ice and travel as fast as possible to the recipient hospital, and you have time for about 4 or 5 hours, and then it could be successful. That doesn't work. That treatment ends in about 60, 70, 8% of the cases with a dead heart and a dead recipient within 48 hours. So porcine hearts are more vulnerable than human hearts. But this is a picture. Just keep that in mind. You will see the picture. No, you will not see it. Barteley Griffith will show the picture. It's very similar to the picture we all have seen from Maryland. So we introduced together with 16 the non-ischemic heart preservation. The solution is hyper-oncotic, and the hormones, certain hormones are added, and it's cool. It's 8 centigrades. There's a little erythrocytes out there, 10% erythrocytes. That's for oxygen transportation. You can argue what kind of erythrocytes, porcine ones from the baboon, or you could use human ones as well. That doesn't matter. Now, my thing is not working again. I'm sorry that I have all these problems and causing the delay. Now it works again. Maybe it's a long distance to Brazil. It's just an example how it looks within the first 8 postoperative days. There's troponin. Troponin is an enzyme which is released from the heart, and it decreases, it's increased. Not much, it's just 1 microgram, that's not much, and decreases. That's normal. Then the kidney function is always good. I forgot to say that our heart is always cool, 8 centigrades, and we even intermittently perfuse it during implantation. But the body of the recipient remains warm, 34 centigrades. So the kidneys are not involved, and the bilirubin liver function, it's a little bit increased, probably due to hemolysis, but then it's normal. So that's done, successful porcine heart preservation. That may be possible for up to 24 hours. So you can fly everywhere in the country, or in Europe, or in North America, or in Asia, whatever you need. Now we run into another problem, a very strange problem. A pig grows very quickly, increases in weight. So within 5 months, it's 400%, and the baboon, of course, doesn't increase. So, and what we found, to our great astonishment, that the pig heart obviously doesn't realize it's in a baboon. It still thinks it is in the pig, and it must go rapidly because the body weight of the pig increases. Well, and though we found out that growth of a pig heart is genetically determined. This is the size of a pig heart. That's the same of the explanted baboon heart, weighs about 50 grams. And after 6 months, a pig heart of a German landrace pig without any growth inhibition would then weigh 250 grams. And after a year, it would weigh almost a kilogram. Of course, ridiculous in a baboon of 15 kilograms, or in a human weighing 80 or 90 kilograms. Now, intrinsic genetically determined growth was halted mainly with rapamycin as a growth hormone inhibitor, and that is our preclinical solution. That's why we were successful. And you can see how hard it looks like if you don't do that. You end up with diastolic pump failure. And if you want to stick in your small finger in the cavity of the left ventricle, you can't do it. And the animals succumb to diastolic pump failure and to liver failure within a month. We could avoid that with rapamycin successfully, and we were then successful in 6 out of 8 continuous or consecutive cases, at least for 3 months and 2 for 6 months. And we lost these 2 to PCMV infection. And ever since, we didn't lose any baboon because we only use now PCMV negative animals. And this is how the hearts are pumped very well. No diastolic pump failure, no systolic pump failure. No reaction, no immunological, so the anti-non-gal antibodies, IgG, remained always flat, no increase. This is a control that heart was rejected acutely. Now, in the clinic, you need different solutions to avoid that growth. And so we introduced, Professor Wolf's group introduced growth hormone receptor knockout. And you see that the animals are smaller, and accordingly, the hearts are smaller when compared to wild type animals. So these animals are ready for clinical use, and that was used in the Maryland case you will hear in a moment. We would prefer another solution, and has to do with James Cook and his immediate followers. They had only small sailing boats, and they had male and female pigs on board, but they couldn't eat them. Then they wouldn't have enough meat, so they set out male and female pigs, English heritage, at the island before the French Revolution. So they sit there, the followers of these animals, and they are the cleanest animals in the world. And actually, Paul 10 told you already about them. They have them, they're beautiful animals, toy animals, and they are white and dotted or black, very gentle animals, slim, not obese, and sows weigh 70 kilograms and boys 90 kilograms, perfect. So we now working on modify them genetically to our needs. So in summary, preclinical results match clinical requirements. Clinical pilot study is planned and ethically justified since the estimated benefit will outweigh their risk. Well, I apologize that there were some edges in my talk. I don't know why I prepared properly, but thank you for listening.
Esse que acabou de chamar Bruno. Doutor Bruno, nós agradecemos muito a sua apresentação. Eu chamo a atenção ao fato que o senhor obteve resultados muito melhores com os animais livres de citomegalovírus, usando aqueles animais da Nova Zelândia que já foram comentados. Nós deveríamos ouvir agora a palavra do Dr. Barteley Griffith, mas ele, por uma razão de dificuldade aérea, a mesma que afetou o Dr. Jorge Kalil, nós ouviremos em seu lugar um seu assistente chamado Corbin, a quem eu dou a palavra agora. Dr. Corbin, a palavra é sua. Dr. Corbin, are you listening to us? No, listen. Okay. But we are not listening to you.
Perfect. Okay, thank you. Let me share my screen here. Okay, can everyone see my screen okay?
Yes, everything okay.
Okay, great. So my name is Dr. Corbin Gerlich. I am presenting on the behalf of Dr. Barteley Griffith and Dr. Mohammed Mahidin in the Cardiac Xenotransplantation Lab at the University of Maryland School of Medicine. And I'd like to thank the National Academy of Medicine of Brazil for the invitation to speak today, and we have no conflicts of interest. So many people have wonderfully summarized what is nothing short of 20 to 30 years of work in xenotransplantation, and specifically in cardiac xenotransplantation with Professor Reichardt, who also presented some of Professor Wolf's work, and then work earlier presented in the first session. But what I want to bring your attention to is I don't know if you guys can see my pointer. Let me see if I can do that. Can you see my pointer?
Your pointer?
Okay. Yes. So essentially what this slide demonstrates, instead of going through all of our preclinical data and the preclinical data of many others, this just demonstrates very nicely that if you take what we call a multi-gene edited pig with multiple complement regulatory proteins, multiple thromboregulatory proteins, and multiple anti-inflammatory proteins, along with multiple antigenic carbohydrate knockouts, and what Professor Reichardt has already demonstrated with growth hormone receptor knockout, genetics as well, in addition to novel immunosuppression through the CD40, CD4 ligand pathway, and novel cardiac preservation with Professor Reichardt's group and Professor Stigstein's non-ischemic continuous preservation, you can then essentially get long-term survival, which has been first demonstrated by Professor Reichardt's group, but then also our group. And what has essentially led to what I will speak about today is initially demonstrated by Professor Mohammed Mahidin at the NIH, or the National Institute of Health, with up to 945-day rejection-free survival in an abdominal heart beating model. And then what we demonstrated up to 9 months, and similar to Professor Reichardt's group, is consistent long-term survival in a life-supporting model, which led us to approach the FDA for a pre-investigational new drug application to the FDA and a meeting, which is known as an INTERACT meeting. I apologize, those are their acronyms and not ours, for a multi-center formal investigational new drug application of cardiac xenotransplantation that could likely happen within the next 18 to 24 months. However, in parallel, we applied for an expanded access, or what is also known as a compassionate use authorization, with the FDA. as a patient presented to our hospital with really no other options. So we had a 57-year-old male with chronic mild thrombocytopenia, hypertension, non-ischemic cardiomyopathy, and previous mitral valve repair, who required hospitalization for severe heart failure with an ejection fraction of 10%. His care was escalated to include multiple IV inotropes and the placement of an intra-aortic balloon pump by hospital day 11. Despite this, he suffered multiple ventricular arrhythmias with arrests requiring resuscitation and was emergently placed on peripheral VA ECMO on hospital day 23. After this, he underwent a thorough investigation for standard therapeutics such as ventricular assist device, total artificial heart, and allotransplantation, but due to non-compliance, sarcopenia, and his non-ambulatory status, he did not qualify. So we approached the FDA December 23rd, 2021, with an application for compassionate use authorization of cardiac xenotransplantation, and it was approved 7 days later on New Year's Eve. In parallel with this process and in conjunction with this process, this application underwent ethics committee approval and institutional research board approval as well by our institution. And additionally, this patient underwent psychiatric evaluation for capacity, including one external evaluation. Informed consent was also obtained for the patient, and this process was approved by our local institutional research board, our ethics board, our university at large, and the FDA. And our expanded access or compassionate use authorization application with the FDA included this 10-gene edited xenograft or source animal that provided the xenograft, an anti-CD40 monoclonal antibody, and the ex vivo perfusion system, which is a commercialized version of Professor Reichart and Professor Stigstein's non-ischemic continuous preservation. And institutional approval was obtained January 6th, 2022. The source animal was screened for notable pathogens of concern, including porcine endogenous retrovirus A, B, and C, for porcine CMV, and for porcine lymphotropic herpesvirus and typical allotransplant pathogens. Source animals from this facility undergo rigorous herd husbandry, including early weaning that Professor Reichart spoke about, and the use of biosecure facilities and routine pathogen surveillance. And all pigs are also derived from a PERV-C negative cell line, and each animal is tested every 3 months for all of the above listed pathogens that impact porcine and or human health. Our source animal was screened for all pathogens of concern and were negative except for the known porcine endogenous retroviruses A and B, which cannot be eradicated, but have never been shown to result in human disease. The recipient was also evaluated for xenograft-specific antibodies and cytotoxicity to the source animal peripheral blood mononuclear cells and was deemed acceptable. This immunosuppression also largely mirrored our non-human primate experience using an anti-CD40 monoclonal antibody-based immunosuppressive therapy, the ex vivo perfusion system, and the quote multi-gene pig. But we had to balance preoperative leukopenia of the patient and baseline thrombocytopenia of the patient prior to induction. And additionally, this patient was also on 6 weeks of VA ECMO therapy prior to initiation of the xenotransplantation. The induction did consist of anti-CD40 monoclonal antibody, ATG, Rituxan, and C1 esterase inhibitor, but the doses of Rituxan and ATG did have to be adjusted based on the preoperative leukopenia and thrombocytopenia. And maintenance did consist of anti-CD40 monoclonal antibody therapy, MMF, and steroids, but as I'll mention here in a minute, the MMF had to be held on day 21 through day 53 with the low tacrose bridge. So the xenotransplantation was successful after a reduced sternotomy and repair of a type A dissection that required a circulatory arrest for a second time. This was from the aortic cross clamp from cardiopulmonary bypass. This was repaired without issue despite a second circulatory arrest, and the xenograft functioned normally despite that second arrest as well. But the patient was left on ECMO to exercise caution and was successfully weaned from ECMO on postoperative day 4. And notably, his left ventricular ejection fraction remained normal throughout his postoperative course. This is just a picture that is actually one of my favorites of Mr. Bennett. You can see he's free from ECMO, he's free from invasive mechanical ventilation, and he's undergoing active rehabilitation, simply because we placed a porcine heart within this individual. And you can even see, although he was certainly very sick before transplant, a nice smile on his face. And this is what the xenograft looked like several weeks after xenotransplantation, and it looks beautiful and it's performing remarkably. However, his postoperative course was not without some significant events. So on postoperative day 10, he did require an exploratory laparotomy for concern of an acute abdomen. And we did find isolated purulent ascites, but without any reasonable source or bowel ischemia. On post-op day 20, you can see here, as indicated by this arrow, we did unbiased surveillance of both human and porcine pathogens by microbial cell-free DNA analysis of the serum longitudinally in this patient after transplantation, and did find DNA content that was porcine CMV derived. But we were unclear of the significance given that our screening did not suggest that this donor had porcine CMV. But on postoperative day 21, we did stop MMF for a reduced white count and a reduced and worsening neutrophil count, but we were able to give granulocyte stimulating factor with good response. He received an endomyocardial biopsy on post-op day 34, which is indicated by this number 1 here, and as you can see by my arrow, and it was remarkably completely normal. You can see here, this green line is a trend of his troponin, which was elevated after transplantation as expected and came down nicely. And his donor-specific antibodies for IgM and IgG remained below or at transplant levels throughout his postoperative course up until day 43. At this time, he did have some concern for sepsis, and he also had hypogammaglobulinemia. So we elected to broaden his antibiotics and administer IVIG. He recovered well from that episode on post-op day 43, and by post-op day 49, he was out of bed to the chair, undergoing active rehabilitation, and even that morning, he waved to us as we rounded in the morning. But pretty peculiarly, by post-op day 49, in the very, very late evening and early morning into post-op day 50, he developed severe undifferentiated shock and required rescue ECMO in order to figure out what may have been occurring. He immediately received an endomyocardial biopsy on that day, and it demonstrated interstitial edema, red blood cell extravasation, and some IgG deposition, but was negative for cellular infiltrate, complement deposition, or intravascular thrombosis. And his ISHLT score as well was 0 for both cellular and antibody-mediated rejection. And as you can see, during this time, you can see this is the second endomyocardial biopsy. He did have a rise in his troponin prior to that, but with a reassuring biopsy and donor-specific antibodies that remained low and acceptable, and an ejection fraction of his heart which remains normal, it was unclear the significance of this troponin. But when he had a clinical status change and we received this endomyocardial biopsy, we elected to initiate treatment for possible atypical antibody-mediated rejection with an additional dose of IVIG, Rituxan, and plasmapheresis. A repeat endomyocardial biopsy at that time on post-op day 56 demonstrated resolution of edema, but areas of fibrosis developed. And after consulting with the family, we compassionately withdrew ECMO on postoperative day 60. Comprehensive autopsy was performed at that time, which confirmed longitudinal biopsy histology, and no PERV transmission was noted. So the working hypothesis as to what may have occurred, we have 3 hypotheses: either rejection, effects of administration of IVIG, or porcine CMV infection within the xenograft. However, we the pros and cons to suggest either rejection or some other hypothesis are as follows. So we did have to limit immunosuppression that was developed from our preclinical model, but there was no evidence of rejection on longitudinal biopsies or autopsy by standard ISHLT criteria or xenotransplantation criteria. Could it have been the administration of the IVIG? It's certainly possible, but preclinical data from Professor Cooper's lab and our own preclinical data and data from using IVIG lots that were administered to this patient did not demonstrate any evidence of complement-dependent cytotoxicity, suggesting that maybe this is not the cause of the xenograft failure that we witnessed. And then the last hypothesis was, could this have been a porcine CMV positive xenograft that attributed to xenograft injury and ultimate failure? But there was no evidence of cytopathic changes on autopsy histology by either H&E, and even scanning electron microscopy did not show any evidence of virus in any portions of the heart. And additionally, we did not demonstrate any cytopathic changes within any thoracic or abdominal organs within the recipient, suggesting that if there is porcine CMV within the xenograft, it did not get transmitted to the patient. So I want to end with a couple quotes. The first is from Mr. Bennett Jr., our patient's son, who you can see in this dark green polo shirt on the right-hand side, being embraced by his father, our patient, and with many family members. And he told us this after Mr. Bennett's passing, but also was quoted in the New York Times as saying, "We hope that this story can be the beginning of hope and not the end. We hope that what was learned from his surgery will benefit future patients and hopefully one day end the organ shortage that costs so many lives each year." And of course, everyone's familiar with this quote, which may have been attributed to Professor Shumway, Professor Starzl, or even Professor Morris. But the quote is, "Xenotransplantation is the future and always will be." But we'd like to say now that xenotransplantation is the future and is here to stay. So in conclusion, the preclinical model of cardiac xenotransplantation largely mirrors the human experience in xenograft life-supporting function and rejection-free survival using CD40 co-stimulation blockade immunosuppression. The non-ischemic continuous preservation does appear to prevent PCXD, as demonstrated in the orthotopic non-human primate model by Professor Reichardt's group and our group. And the application of cardiac xenotransplantation requires careful consideration of clinical factors that cannot be assessed by orthotopic non-human primate models. And more clarity in the pathophysiology of acute diastolic failure is required to help identify antecedent markers of xenograft failure. And additionally, more sensitive assays may be required for pig source animals to better assess latent viruses such as PCMB beyond what was used in this patient. Thank you to the University of Maryland Xeno Heart team. Thank you to the National Academy of Medicine of Brazil, and thank you to the National Institutes of Health and United Therapeutics for funding this work. Thank you very much.
Muito obrigado, Dr. Corbin, pela sua completa e extensa exposição. Eu passo agora a palavra ao professor David Cooper, que sucessivamente foi pesquisador sênior em transplantes na Universidade de Pittsburgh, na Universidade de Alabama e atualmente trabalha no Massachusetts General Hospital. Dr. Cooper, a palavra é sua. Are you listening?
Yeah, I'm here. We're just getting the slides.
Yes, we have here. Everything's fine.
You can see the slides?
Yes, we can.
Okay, good. Can you get them up?
Okay.
Coloca no modo apresentador.
Okay, well, thank you very much for the invitation to participate in this very interesting symposium. I've greatly enjoyed the last three speakers. So I'm going to give you a few perspectives on xenotransplantation. I'll concentrate a little more on the kidney, as we've had two presentations about the heart, but some of the comments I will make will be very general and cover every organism, every organ. So I'm a consultant to eGenesis, which is a company that is making pigs here in Massachusetts. But what I'm going to say, of course, is my own opinion, not that of eGenesis. So the topics I'm going to briefly discuss are some general comments. I'm going to mention the pathobiology of xenotransplantation, which Bruno Reichert has already covered a little bit. I'm going to give you a couple of comments about these triple knockout pigs, where all the three antigens that are present in pig tissues that we know humans have antibodies against are knocked out. I'm going to make a comment about immunosuppressive therapy, about the diagnosis of rejection of pig kidney grafts, a little bit about pig kidney function in non-human primates, a comment about public opinion on xenotransplantation in the USA, and then some comments about moving to formal clinical trials of pig kidney transplantation and the selection of patients for clinical trials. So first of all, I want to make this very important point, which we all take for granted, but I think it's worth emphasizing. This is the first opportunity in the last 70 years while we've been doing organ transplants. This is the first opportunity we've had to modify the donor rather than just treat the recipient. And that's an extremely important possibility. And I believe that over the next 2 or 3 decades, we will eventually end up where we will need no treatment for the recipient, because we'll be able to modify the donor in such a way that it is resistant to the immune response of the primate. So it's an important topic that we now can concentrate our attention on the donor rather than just the recipient. Now, we're talking today about heart and kidney transplants, but I want you again to remember that we're talking about all organs. Eventually, the liver and the lungs will be suitable for transplantation. And there have been some very good studies on pancreatic islet transplants, hepatocyte transplants, corneal transplants, transplants in Parkinson's disease, red blood cell transfusion as opposed to human red blood cell transfusion, and obviously a lot of work previously on heart valves and tissues. So this is going to have an enormous impact on medicine, the fact that we have basically universal donors for any tissues that we want to transfer to a patient. Now, the pathobiology of pig organ xenotransplantation is rather more complex, as you've already heard from Bruno, compared with the pathobiology of organ allotransplantation. And we can overcome this by immunosuppressive therapy. We need to know more about the diagnosis of rejection, pig kidney function, and selection of patients. The innate immune response is very complex. It causes antibody binding to the graft, activates complement. We've heard about coagulation dysfunction, which is a major factor. There's a systemic inflammatory response to the graft, and there are problems with the recognition of self. Some cells in the human body recognize other cells as self, but they don't recognize pig cells as self, and that complicates the response. Now, what can we do about this innate immune response? It's not susceptible to the standard immunosuppressive therapy we give. So we have to do something else. And this is where the gene-edited pigs come in so fully. And what we've done is deleted the expression of the 3 known pig xenoantigens against which humans have antibodies. And we've introduced human protective genes, as in the 10-gene pigs that Corbin told us about, that was used in the heart transplant patient. But in addition, of course, there's an adaptive immune response, as you would see in any patient with an allotransplant, mainly due to T and B cell activation. And there again, as Corbin mentioned, we can give immunosuppression, but it's got to be different immunosuppression from that which we give to patients with an allotransplant. The standard conventional immunosuppressive therapy does not fare very well when you're trying to suppress the response to a xenograft. And so we've all honed in on blockade of the CD40, CD154 co-stimulation pathway. Once the antigen is recognized by the T cells, they need this pathway to allow them to react against the T cell, to activate them. And if this pathway is blocked, they don't react against the graft. They're just quiescent. And this is proving very valuable. was first introduced by Leo Buehler in 2000 in xenotransplantation. Now, the problem with the triple knockout pig, which is going to be ideal for patients, it's not ideal for old world monkeys, which are the model that we're using, of course, in the experimental laboratory. Many humans have no serum antibodies against triple knockout pig cells, which of course is excellent news, because if they have no antibodies, there's a much less chance of them activating the complement system and so on. But all old world monkeys have serum antibodies to triple knockout pig cells. I won't go into the reasons why. We do know why, but it's unfortunate that this model now that we've been using for decades is no longer really relevant to the human model, because we now have recipients who all are sensitized to the pig organ, whereas many humans will not be sensitized because they won't have any antibodies. So that makes life very difficult for us. And here's an example from our own studies. You can see in the red line is the survival of triple knockout pig kidneys in baboons, and the black line is the knockout of gal knockout, is the survival of gal knockout pig organs, pig kidneys in baboons. And you can see, using the simpler model of the gal knockout, when only one is knocked out, we get a better result than if we knock all three out. And we understand why that is, but I'm sure we'd see the reverse if we were putting these grafts into humans. So this is a major problem to us. So this has hindered progress in the pig to non-human primate organ transplantation model. You can get over this problem, as exemplified by Corbin's work, but it has been more difficult to do that. But nevertheless, because it's been shown that the non-human primate model is a difficult one, it has stimulated the move towards clinical trials. So because we no longer have a model that really represents the situation with the pig to human transplant. So on the basis of in vitro serum cytotoxicity of pig cells, the results of pig organ transplant in humans should be significantly better than in old world non-human primates. And so that's why many of us are very keen to begin clinical trials, because we think the outcome will be better than if we struggle on with the non-human primates. Now, the immunosuppressive therapy I've already mentioned, the conventional therapy, for example, tacrolimus-based, is really inadequate in xenotransplantation. We and several other groups have shown this. And blockade of this co-stimulation pathway, not the CD28B7 pathway that belatacept is involved in, but a different pathway, the CD40, CD154 pathway, is required. And here again is another chart from our studies. You look again in the red, that is the survival of pig kidneys in baboons that receive conventional tacrolimus-based therapy. And you can see virtually none of them survive more than a month. But when we use the CD154 or CD40, CD154 pathway blockade, you can see we had much better survival going out to approximately 9 months. There's a very significant difference. We have to learn that we've got to use a different immunosuppressive regimen when we come to do clinical xenotransplantation. Now, our immunosuppressive therapy is very similar to that used by the Maryland and the Munich groups. We've used ATG, a relatively low dose, 5 milligrams per kilo of days -3 and -1. Very low dose of rituximab, an anti-CD20. We only give 10 milligrams on 1 day, whereas the standard dose for treating patients with lymphomas and so on is to give double that dose on four occasions over the course of a month. So we've given a very small amount. We use systemic complement inhibition. We used to use cobra venom factor. We've used C1 inhibitor after Bruno's exploration of it, but again only on 2 days, days 0 and 2. The maintenance, and that is key, is the anti-CD154 agent. Rapamycin we've been given, and that's where we realized that rapamycin might be reducing the growth of the pig organs. And we've used a lowish dose of methylprednisolone, tapering quite rapidly to just a standard routine dose. Now, many of us have given systemic anti-inflammatory therapy because we know there's a systemic inflammatory response after xenotransplantation. And because of this coagulation dysregulation, we've given an anticoagulant or antiplatelet therapy. Whether these are necessary with these 10-gene pigs is really not certain, and I suspect they're not necessary. But most of us are still giving some antiplatelet therapy in the form of, say, aspirin and so on. Now, one thing for the future, and even for the present, we and Revivicor and the Munich group have shown that genetically engineered pigs pigs can be genetically engineered so that they secrete some immunosuppressive agents, for example, CTLA-4 Ig. So I think that eventually we'll have pigs and the organs will be transplanted. They'll be protected against the human immune response. But in addition, they will make their own immunosuppressive agents. Now, what will be difficult is to know how much of this agent they need to secrete. When we did this initially with Revivicor, the pigs themselves were making so much of the CTLA-4 Ig that they immunosuppressed themselves and were very prone to infectious complications before we ever transplanted the organs. And so obviously that was too much. But if you put the gene in just a certain group of cells, such as islets, which the Munich group have done, then you get a much less secretion of the agent, but it may be enough to allow some immunosuppressive effect after the transplant. Now, what about the diagnosis of rejection of a kidney? It's very much the same now as with the diagnosis of rejection of a human kidney transplant. It never used to be. It used to be platelet dropping and fibrin dropping. But now it's based on increased serum creatinine. You have to exclude hypovolemia because that can push your serum creatinine up, and you can isolate that by a biopsy, for example, if it's rejection or not. You see increased proteinuria in every case, and we see a decreased renal blood flow on ultrasound. So that's how we're diagnosing rejection, very similar to what you do with a human organ transplant. Immunological markers of rejection with regard certainly to a pig kidney, and I think also to a pig heart, are really not very helpful. Anti-pig antibodies may be measurable, but often they're not measurable because they bind to the graft. And only if you take the graft out, you see a real increase in the antibodies. Obviously, you can't take out a life-supporting kidney or heart, but if you put in a heterotopic heart, and we've seen in the past, once you take that out, then you see an increase in antibodies, but they're not very helpful if you have a life-supporting organ. And T and B cell numbers are depleted by the ATG and the rituximab, and with this regimen, they remain at about 30 to 40% of the baseline numbers, and they don't seem to change. So we think they're non-informative rejection. You do not see an increase in T cells in the blood when you're getting rejection. So immune markers are not very easy at the moment. They'll probably be more sophisticated ones in the future, but at the moment, the standard measurements of whether you've got rejection are not helpful. And therefore, I think we will initially have to rely more on renal biopsies than we do with an allo transplant. And I noted that Corbin did a number of biopsies on the heart transplant patient. So we're going to have to rely on biopsies until we get more experience with clinical trials of patients with heart or kidney transplants. Now, what about the pig kidney function, which is obviously very important? Serum electrolytes remain largely in the normal range. Pig urine concentrating ability is reduced. Pigs do not concentrate their urine very well, so they have to pass more urine to keep the creatinine and so on stable. And we've certainly seen some periods where they have they get dehydrated. I think because those pig kidneys passing more urine than the baboon would normally do so. And here's an example of that. This was a baboon who you see about 40 days after the transplant got a sudden rise in the serum creatinine. We immediately thought, of course, that it was undergoing antibody-mediated rejection, where you can get a rise this quickly without any doubt. So we took it to the operating room and did a biopsy. And while we were doing the biopsy, you can see by the arrows there above the peak creatinine, we gave intravenous fluid. We gave this partly because we noticed when we anesthetized the baboon that the blood pressure was low, about 70 systolic, and the venous pressure was almost 0. And we felt this baboon was very hypovolemic. So we gave him quite a lot of fluid at that time. And within hours, in fact, the creatinine came down and the biopsy showed no sign of rejection. So this warned us that you can get a fairly acute hypovolemia or dehydration in the baboons that do not appear to realize they're getting so hypovolemic or dehydrated. And you reverse the serum creatinine rise just by giving fluids, and it's nothing to do with rejection. And this is quite an important observation, I think. So if a rise in serum creatinine is related to hypovolemia and dehydration, it is not usually associated with increased proteinuria. If it is a result of rejection, we usually see increased proteinuria. So that's a way of differentiating the two conditions. And if you didn't pick up the hypovolemia, you could be treating the baboons unnecessarily with increased immunosuppressive therapy because they don't have rejection going on. So this is an important differentiation to make. Now, what about the function? We wondered if this hypovolemia and dehydration was a result of discrepancies in the renin-angiotensin-aldosterone system between pigs and baboons. And I won't go into the details, but we've recently shown that this system is functional in non-human primates with a pig kidney. So it's not due to a functional disturbance in that system, which maintains your helps to maintain your blood pressure. And we looked at the glomerular filtration rate, and in the absence of rejection, the glomerular filtration rate was decreased post-transplant, but was maintained within the normal range. There seemed to be some reduction, but it was maintained in the normal range. So we believe that kidney function is adequate as far as we've been able to measure to date after the pig organ is transplanted into the baboon. And the fact that there are monkeys around now by several groups with pig kidney grafts surviving for more than a year, and in one case up to more than 3 years, this strongly suggests that the pig kidney is fulfilling all of the functions of a non-human primate kidney. If it were not, you would not expect to see a healthy baboon or monkey a year later. Now, if there are functional deficiencies, either with the kidney or particularly, say, with the liver, these could, of course, be corrected by genetic engineering of the pig. For example, if the pig were not making the right albumin, then you could put a gene in for human albumin into the pig and the liver would make human albumin. So again, this is another advantage of genetic engineering. Now, we did several surveys in the last few years when I was at the University of Alabama, and our surveys suggest that hospital staff, patients, and the public are generally supportive of xenotransplantation, particularly if we can guarantee them that the results will be comparable to allotransplantation, which of course we can't, but they were generally supportive. African Americans, in contrast, had significant reservations, which I think goes back to historical clinical trials, which were not of a high ethical standard. And so they're much more reluctant to participate in a clinical trial, I believe. Now, what experimental results would justify a clinical trial of, certainly of kidney transplantation? And Bruno covered this a little bit. We suggest that something like survival of 6 of 8 non-human primates with a life-supporting pig organ for 6 months, with perhaps 1 or 2 of them at least going on to 12 months. So you could more or less expect the patient to do well for perhaps up to a year at least would be a reasonable thing. You're always going to get some deaths or complications in the pig to non-human primate model. There are problems such as gastric dilatation, which is quite lethal not in baboons, that you don't see very commonly in patients, or you can treat it in patients. And the absence of clinical, we would need obviously also the absence of clinical or histopathological features of irreversible rejection or life-threatening infection. It would not be adequate to get up to 6 months and have a patient rejecting all the time or having a life-threatening infection being treated. So we'd have to have evidence that the immunosuppressive regimen not only prevented rejection, but was not causing undue infectious complications. And I stress this again, as we all know in the field here, that progress will be significantly greater when patients are being treated in a hospital setting compared with where the facilities we have to treat non-human primates. Corbin showed this clearly. That patient required immense care, which you could not possibly give to a non-human primate. The non-human primates don't live in very hygienic conditions. They can't communicate with you. We haven't got access to sophisticated investigations as you have in a hospital, and we certainly don't have really intensive care in the laboratory. So we should expect the results to be much better, I think, for a number of reasons when we move into the clinic. Now, what about the selection of patients for the first clinical trial of pig kidney transplants? Well, we believe that patients who will likely never receive a deceased donor kidney allograft, no matter how long they stay on the waiting list, these should be considered carefully as potential patients for the first clinical trial. These are generally patients perhaps aged over 60. They're of blood group O, where there's a more limited number of human organ donors, and possibly they should be diabetic, because there is no doubt that diabetic patients do less well on the waiting list than non-diabetic patients. And I'll give you an example here. This chart, I think, is particularly important. If you look at the curve of wait list while on dialysis, these are patients on the waiting list waiting for a kidney transplant. So they've been selected as suitable for a kidney transplant, but they've been told they've got to wait on dialysis until a suitable human organ becomes available. And you'll notice that at 60 months, 5 years, nearly 50% of them are either dead or they've been taken off the waiting list because they're no longer suitable candidates, even though they were when they were put on the list. And we believe that those patients, and you could often predict them because of their age or their blood type and so on, the fact whether they have diabetes or not, they would be patients that might well benefit from a pig kidney transplant and may be very keen to have a pig kidney transplant. I don't think these patients, when they're put on the waiting list, are told that there's a 50% chance they're going to be dead or off the waiting list in 5 years' time. I think they're told they've got to be patient, and it would obviously be very bad for their morale and their optimism if you told them the exact result of being on the waiting list for a long period of time. But I think these patients, if it's explained to them what the likely outcome is of remaining on dialysis, they might be very keen to have a transplant. Obviously, they should have no other major comorbidities, except, I say, possibly diabetes. They should be selected because they're good candidates for allo transplant, but they can't get an organ. And they should have no anti-HLA antibodies that cross-react with SLA. Now, there aren't very many patients with anti-HLA antibodies who have antibodies that do cross with SLA. So many of those patients would be suitable for a pig kidney transplant. Now, in concluding, it's unrealistic to anticipate uniformly good prolongation. That means several years of graft and recipient survival when we begin real formal clinical trials of xenotransplantation, whether it's the heart or the kidney. But initially, the pig graft may prove to be a bridge to allotransplantation, particularly, say, in infants with congenital heart disease who are waiting for a human deceased organ of the right size, or even in patients who are on dialysis. And if you could tell them they wouldn't be on dialysis, they'd be able to forego dialysis for months or even a few years, I'm sure many of them would be very pleased about that because dialysis, as you know, is not very popular with patients. So we're looking more, I think, not at destination therapy, but more as a form of bridging in some way or other, I think initially. Now, my former mentor, Christian Barnard, who, as you know, did the first heart transplant in 1967, he once said to me, you cannot stay in the laboratory forever. And I think we're at a stage now when we've been in the laboratory long enough. We know what immunosuppression we want to give. We know which pigs we want to use. We know a lot of other things. We know how to diagnose rejection, et cetera, et cetera. So I think we're now at a stage where we should move out of the laboratory into the clinic and do some small, carefully organized clinical trials. And I think we'll learn much more from that than if we stay in the laboratory working with a model that is no longer really very relevant to what we're trying to do. So thank you very much for your attention.
Dr. Cooper, I thank you for your universal lecture.
Thank you.
Really, it was an overwhelming description of the problem. Eu passo agora a palavra ao acadêmico Rosano Fiorelli, que comentará apresentações do primeiro bloco. Segundo bloco, perdão. Fiorelli, você está me ouvindo? Fiorelli?
Acadêmico Silvano Raia, estou ouvindo.
E nós ouvindo você, pode falar.
Muito bem. Boa noite, excelentíssimo presidente da Academia Nacional de Medicina, acadêmico Francisco Sampaio, ex-presidente e mestre eterno acadêmico Pietro Novellino, senhores acadêmicos, senhores convidados, presidente da sessão, acadêmico Silvano Raia, eu agradeço o convite de participar desse simpósio realmente com uma relevância muito importante no atual cenário nacional e internacional, e dizer que ouvi atentamente as conferências dos professores Stam, Reichardt, Gorlick e Cooper, que realmente foram conferências magnânimas. O xenotransplante é uma realidade e vem para tentar resolver um problema muito grande, que é a oferta e demanda de órgãos para transplante, que não consegue suplantar 30%. Histórica e conceitualmente, né, o xenotransplante, a gente lê relatos mais no período filosófico da medicina, em 1667, da xenotransfusão de sangue de cordeiro em humanos, e mais recentemente, em 1935, sem nenhum embasamento científico, xenotransplante de rim de coelho em humanos. O fato é que, realmente, o xenotransplante vem para tentar resolver um problema muito grande, que é a oferta e demanda de órgãos para pacientes com aumento da expectativa de vida e a falha pontual de alguns órgãos, da substituição desses para prolongar a vida. E medidas, assim como no xenotransplante, como outras alternativas potenciais para aliviar a escassez de órgãos humanos em transplantes, como quimera humano-animal, por várias técnicas, incluindo biotecnologia de células-tronco, medicina regenerativa e complementação por blastocistos, além de abordagem para gerar órgãos por tecnologia de impressão 3D e andames descerularizados in vitro, o xenotransplante é o que temos de realidade e mais avançado. Como pôde mostrar o professor Gorlick no xenotransplante cardíaco que foi realizado recentemente, e que, como toda inovação, como inovador, suscitou vários editoriais em revistas, alguns deles questionando a questão, uma das questões que vem à voga com relação ao xenotransplante, que é a questão da parte ética, não é? De forma que todas essas apresentações realmente foram muito apropriadas nesse momento. Eu acho que a parte de transplante ela é muito restrita aos especialistas e deve ser difundida, principalmente para a sociedade, como mostrou o professor Cooper, que certamente qualquer paciente que faz hemodiálise há muito tempo gostaria de ter a possibilidade de ter essa hemodiálise suspendida através de qualquer forma e certamente um xenotransplante poderá suprir essa necessidade. De forma, professor Silvano Raia, eu acho que o senhor é uma pessoa estimada e admirada para nós cirurgiões, um espelho para todos aqueles que querem seguir a medicina e a cirurgia, pioneiro no transplante hepático. Aqui eu faço uma reverência também ao professor Camargo, que foi comentarista na primeira etapa, pioneiro no transplante de pulmão no país, de forma que escolheu pontualmente e de maneira magistral esses apresentadores que realmente fizeram apresentações magnânimas e puderam tirar muitas dúvidas com relação ao xenotransplante na atualidade. Muito obrigado pelo convite.
Muito obrigado, acadêmico Fiorelli. Passo agora a palavra ao acadêmico Paulo Niemeyer. Paulo, você está aí? Paulo?
Oi, está me vendo? Está me ouvindo?
Agora sim. Agora sim.
Tá bom. Boa noite a todos. Eu quero cumprimentar o presidente da Academia Nacional de Medicina e dar aqui expressar aqui minha admiração pelo professor Silvano Raia, um querido amigo, grande pioneiro dos transplantes de fígado na América Latina, criador de novas técnicas e uma liderança incontestável da medicina brasileira. Eu fiquei muito interessado, achei extremamente interessante a aula do professor Tan, quando ele fala no transplante de plexo coroide. E o plexo coroide, quer dizer, a ideia geral que se tem é que ele apenas produz líquido, que produz a hidrocefalia quando tem algum distúrbio na circulação do líquido, e existe até uma cirurgia que é para retirar o plexo coroide como forma de tratamento de algumas hidrocefalias. E hoje nós estamos vendo aqui que o plexo coroide é muito mais do que um produtor de líquido, ele produz uma quantidade enorme de fatores de crescimento, de fatores neurotróficos, e que são exatamente esses fatores que interessam nesse transplante do plexo coroide dessas células, não é pela produção do líquido, mas na secreção, na produção desses fatores neurotróficos. Então, eu acho que a doença do Parkinson foi escolhida pela possibilidade até de avaliar o resultado a curto prazo, porque você pode ver a rigidez, o tremor, o comportamento, mas isso abre um caminho muito grande para as doenças neurodegenerativas, como até a doença de Alzheimer, que futuramente poderá passar por isso, porque uma das possibilidades é que essa atrofia, essa degeneração do plexo coroide com a idade e com outros fatores, leve a uma falta a uma ausência uma deficiência desses fatores neurotróficos que formam, quer dizer, esse líquido que banha o cérebro, ele mantém a homeostase extracelular no cérebro. E quando o plexo coroide não está produzindo adequadamente essas substâncias, ele pode levar ao desencadeamento e ser um dos fatores para precipitar doenças neurodegenerativas. Com relação ao Parkinson, é curioso, porque nos anos 70, isso foi tentado com transplante de células da suprarrenal. E os pacientes tinham uma melhora. Os resultados eram muito controversos, mas muitos pacientes tinham melhora, mas uma melhora transitória, que durava ali 1 ano e voltava a piorar. Então, não se sabe se esses pacientes melhoravam também pela produção desses fatores neurotróficos, que eram ali deixados, ou até pelo trauma cirúrgico de introduzir as células, porque uma das técnicas cirúrgicas no tratamento do Parkinson é exatamente a lesão do núcleo. Então, seria até interessante saber aonde essas células foram, em que região do cérebro, com que técnica elas foram introduzidas no cérebro. Porque uma das possibilidades que se aventava na época do transplante das células suprarrenais era que o próprio método de introdução já fazia a lesão e já tratava o doente, assim como a cirurgia. Então, às vezes, é difícil avaliar exatamente o que está trazendo a melhora. Agora, essa possibilidade de trazer células do porco é um mundo novo. Isso aí é uma como experiência, como ideia, é um campo novo e vai trazer uma possibilidade enorme para se entender essas doenças neurodegenerativas. E mesmo com relação ao Parkinson, eu não acredito que isso vá curar o Parkinson, mas isso poderá trazer melhora. Esse plexo coroide produzindo essas substâncias, ativar esses neurônios que ainda estão vivos, quer dizer, a gente sabe que é uma doença degenerativa, e provavelmente os doentes mais jovens, que têm numa fase mais inicial da doença, deverão ter uma resposta melhor a um tratamento como esse. Mas é uma ideia, é um campo novo, é um mundo novo, imaginar que células de um animal possam produzir fatores neurotróficos que vão estimular o sistema nervoso central do homem. Eu quero parabenizar o professor Poltan pela brilhante apresentação e por todo o questionamento que isso envolve e que ele trouxe para que a gente possa dormir com isso. Muito obrigado.
Obrigado a você, Paulo, pelo seu comentário muito ilustrativo. Passo agora a palavra ao nosso correspondente estrangeiro, Rodrigo Viana. Ele estava, acho que, viajando para a Holanda. Rodrigo, você está aí?
Estou aqui, sim, professor. Me escuta?
Bem-vindo.
Olá.
Vamos ouvir
Então, muito boa tarde a vocês, o presidente da Academia de Medicina, doutor Silvano, sempre com iniciativas espetaculares e sempre uma fonte de inspiração para todos nós, a todos os demais acadêmicos e aos apresentadores. Fala em português, correto, professor Silvano?
Exatamente.
Ok. Então, eu vou começar primeiro, parabenizo a todos os apresentadores, foi uma tarde fascinante. Eu já estou envolvido com o Xenotransplante faz muitos anos, né? Trabalho com o Joe Tector desde o ano 2000, então são 20 anos. Acho que alguns comentários que eu gostaria de fazer, desde da criação do porco, óbvio que hoje nós temos a tecnologia que antes não estava para nós disponível, que é o CRISPR, mas eu queria salientar algumas coisas. Por exemplo, mostrar que a gente não tem ainda, por exemplo, uma droga que possa, em humanos, ser utilizada, né? Nós temos os bloqueadores anti-CD40 e 154, mas não temos a droga ainda, ela está sendo produzida. Também lembrar que essas drogas imunossupressoras, elas podem causar uma microangiopatia, né? Ou seja, causar trombos no corpo. Então, é importante a gente lembrar, como foi mencionado antes, a importância da trombomodulina e ainda outros fatores que devem ser ainda endereçados na produção deste animal que finalmente será, se a gente conseguir o animal utilizado para o transplante. Em relação aos fatores de coagulação, por exemplo, no fígado, o porco produz em quantidades diferentes que o humano, né? E as funções, às vezes, diferentes. Então, nós vamos ter que adequar a produção desses fatores de coagulação para os humanos. Outra coisa vai ser a produção dos donor-specific antibodies, né? Depois de que esse órgão for colocado no humano, assim como no transplante de humano para humano, existe a formação de anticorpos de novo. Então, essas respostas só vão ser, nós só vamos ter algum indício dessas respostas depois que os clinical trials começarem, né? Em relação às infecções, o FDA exige que esses porcos não secretem o PERV, não só que eles sejam negativos, mas que eles também não secretem os PERVs, né? E voltando às drogas, eu vi, o professor Cooper mostrou que talvez o porco produza o seu próprio imunossupressor. Eu tenho um pouco de caution, né, em relação a isso, porque se você tiver uma infecção, você não consegue suspender a imunossupressão, porque o porco continua produzindo a sua própria droga, né? Então, acho que é importante. Com relação ao crescimento do órgão, eu tenho um pouco de dúvida e alguns trabalhos mostram que isso não é totalmente verdade. O que existe é que existe uma rejeição ainda do órgão que faz com que ele aumente de tamanho. Como você sabe que o growth hormone tem que estar presente para que o órgão continue crescendo. Então, existem já, para que isso fosse verdade, você teria que ter uma histologia negativa para a rejeição. Então, seria só a estimulação do growth hormone. Então, realmente tem um artigo agora recente do Kirk na Transplantation que mostra que esse crescimento talvez seja rejeição e não exatamente a estimulação do growth hormone, porque o receptor tem que ter growth hormone, que não é verdade em animais, às vezes adultos. Então, eu falo um pouco de caution nisso. E, por final, acho que nós temos que desenvolver um cross-matching melhor. Nós desenvolvemos aqui no MTI, com o grupo do Dr. Tector, né? Glycan Blinding Proteins, né? Através do SLA do porco, tanto no classe 1 e no classe 2. Por quê? Porque se você conseguir desenvolver um cross-matching onde você consiga realmente excluir os negativos, vocês podem imaginar que você vai precisar editar menos o porco, você vai precisar de menos imunossupressão e você vai ter menos infecções. Então, o que não é mencionado é que talvez a peça mais importante de tudo isso seja o cross-match, né? Nós temos que pensar nesse cross-match. Por quê? Porque essa é a resposta de tudo, né? Da edição do porco até. E acho que são esses os meus comentários. A gente poderia passar horas aqui falando disso, porque é um tema que me fascina. E gostaria de agradecer mais uma vez, professor Silvano, por essa iniciativa e a todos os palestrantes pelas brilhantes palestras. Muito obrigado.
Muito obrigado, Rodrigo. Ao encerrar esse simpósio...
Obrigado, Silvano. Quem encerra é o presidente. Se tiver alguma coisa ainda para falar,
presidente,
então, eu assumo aqui.
Me desculpe usar o termo. Ao completar o que foi dito, eu gostaria de fazer um comentário final. Eu acredito que, como nas reações nucleares, o xenotransplante atingiu um momento, a chamada massa crítica, que define o ponto de não retorno. O futuro é imprevisível, mas eu acho que foi muito esclarecedor esse simpósio para mostrar o universo que circunda o xenotransplante. É uma atitude muito além do ato cirúrgico. E eu cumprimento a todos, agradeço os apresentadores estrangeiros que, apesar das suas agendas, obviamente, muito solicitadas, nos deram seu tempo e sua atenção. Muito obrigado. Presidente, a palavra é sua.
Obrigado, Silvano. Nós temos ainda a possibilidade de discussão com a bancada acadêmica. Quero saber se algum acadêmico presente na Academia Nacional de Medicina ou algum acadêmico remotamente quer fazer uso da palavra. Se nenhum acadêmico quer fazer uso da palavra, eu pergunto ainda se algum palestrante ou comentarista quer fazer alguma complementação, ou mesmo o nosso organizador, Silvano Raia, pois ainda temos alguns minutos. Não havendo ninguém mais querendo fazer uso da palavra, agradeço ao nosso querido Silvano Raia por ter mobilizado esses palestrantes de todos os cantos do mundo e as pessoas que estão na fronteira do conhecimento. Agradeço muito ao professor Tan, professor Rejeição, professor Griffith, professor Cooper, nossos comentaristas Rossano Fiorelli, Paulo Niemeyer, Rodrigo Viana, novamente o nosso Silvano Raia, e dou essa sessão por encerrada. Obrigado a todos e boa noite.
Muito bom.